Necrotizing fasciitis. The name itself is chilling, isn't it? Often brought up in, well, quite alarming
It
headlines.
is, yes. It grabs attention.
But what does it actually mean? Our sources reveal a condition where perhaps a seemingly minor injury, maybe just a scrape, or even an insect bite?
Something quite trivial, seemingly.
Exactly. It can escalate into a life-threatening emergency with, well, brutal speed.
That speed is key.
It really is a race against time where recognizing incredibly subtle early signs can literally be the difference between life and death.
That's not an exaggeration, unfortunately.
Welcome to the Deep Dive. This is where we take a stack of complex source materials, articles, research papers, notes, and really try to distill them into the critical insights you need to be well-informed, fast.
A very useful exercise.
Today we're tackling a subject that I think really highlights the razor-thin margin between a common ailment and a genuine medical crisis. Necrotizing fasciitis, sometimes referred to, quite dramatically, as the flesh-eating disease.
That popular term, yes. Though not entirely medically accurate, it conveys the severity.
It certainly conveys the horror. Now, to navigate the intricate medical literature and orthopedic resources that form the basis of our deep dive today, we have the ideal guide. With us is someone whose extensive background in orthopedic surgery and medical analysis provides precisely the kind of clinical and academic perspective needed.
Well, I hope I can help shed some light based on the material provided.
I'm sure you can. It's important material, as you say, and I'm ready to help unpack what the sources tell us.
Good. Let's get started.
Thank you for joining us. Your expertise is genuinely invaluable for this. As you noted, this is critically important material. The urgency is almost palpable throughout the sources we've reviewed.
It comes across very strongly in the literature, yes.
So let's jump straight into setting the stage with some high-impact questions, shall we?
Please.
First off, stripping away that sensational name, what exactly is necrotizing fasciitis from a medical standpoint, according to these sources?
Okay, so at its core, necrotizing fasciitis, or NF, as it's often abbreviated, is defined in the sources as a rare, but, and this is the crucial part, extremely aggressive soft tissue infection.
Aggressive in what way specifically?
What distinguishes it is its focus. It primarily targets the fascial planes. You can think of these as layers of connective tissue beneath the skin and surrounding muscles.
Right, sort of structural layers.
Precisely. And it rapidly causes inflammation and then subsequent necrosis, which just means tissue death, not just of the fascia itself, but also the surrounding skin and subcutaneous fat.
Necrosis. Tissue death.
Yes. The critical word is necrotizing. The tissue is literally dying off, and at an alarming rate.
And the sources emphasize that alarming rate incredibly strongly. You mentioned speed. How rapidly can this infection actually progress from something that might just seem concerning to a truly life-threatening situation?
This is perhaps the most frightening aspect the sources really highlight. The progression isn't measured in days, it's often measured in hours.
Hours? Really?
Yes. What might present initially as perhaps a minor area of redness or swelling, maybe looking like a simple boil, can, in a matter of maybe 6, 12, certainly 24 hours, escalate into extensive tissue damage, severe systemic illness, the patient becoming very unwell, and even shock.
Gosh.
And without immediate and aggressive intervention, the sources are very clear.
Yeah.
It can be rapidly fatal. It simply doesn't allow for a wait-and-see approach.
No time for hesitation.
Yeah.
Okay. And given its rapid and destructive nature and the fact that quite a bit of our source material comes from orthopedic contexts,
That's right.
why is necrotizing fasciitis highlighted as particularly relevant for professionals in orthopedics, or perhaps those dealing more broadly with musculoskeletal issues?
That's a really crucial point. Orthopedic specialists, you see, frequently manage conditions involving the limbs, trauma, wounds. They perform surgical procedures on soft tissues and bone all the time.
Sure, it's their bread and butter.
Exactly. And the sources repeatedly link NF occurrence to preceding events like trauma, even quite minor ones like skin breaks, as we mentioned, or as a complication following surgery.
So after an operation, for example.
Yes. Patients presenting with pain, swelling, or perhaps wound concerns in the arms, legs, or trunk, maybe after an injury or postoperatively, are often first evaluated by orthopedic teams.
Right, they're the first port of call.
Therefore, a high level of suspicion for NF within orthopedics is absolutely critical. They're often the first responders, if you like, in potentially recognizing this hidden threat. They need to be able to distinguish it from much more common, far less severe conditions, like simple cellulitis.
That makes complete sense. That contextual relevance puts them right on the front lines of potential recognition. Okay, let's delve deeper then. Defining this threat and identifying who might be most at risk.
Good idea.
You explained that NF attacks the soft tissues and critically spreads along these fascial planes. Could you maybe elaborate a little on these fascial planes? What are they exactly, and why does infection tracking along them make NF so uniquely dangerous compared to, say, a more superficial skin infection?
Absolutely. Think of fascial planes as, well, the connective tissue envelopes or layers that run throughout the body. There's superficial fascia just beneath the skin, then deeper fascia that encase muscles and muscle groups, and even deeper layers still.
Okay, sort of wrapping things up.
Yes, they provide structure, they compartmentalize different tissues. The danger with NF isn't just the infection at the point where it got in, it's how it exploits these planes.
Exploits them? How?
Well, the bacteria and the toxins they produce don't just stay put. They effectively race along these layers. You could almost imagine it like fire spreading through dry tinder,
Wow.
often moving significant distances very quickly, but crucially, beneath the skin surface. This allows the infection to become widespread internally before the visible external signs on the skin necessarily become dramatic.
Ah, so it's hidden.
Exactly. This hidden spread is why it's so challenging to diagnose early based purely on skin appearance, and it contributes significantly to its rapid devastation. The sources make it very clear that this spread along the fascia is a defining pathological feature.
So it's essentially using the body's own structural layers as a kind of highway for the infection.
That's a good way to put it, yes.
That horrifying picture certainly explains the speed and that often delayed recognition. And you mentioned earlier that various microbes can be responsible.
Precisely. It's not caused by just one single type of bacterium, which is important because it influences how we classify it and ultimately how we approach treatment.
Right. Let's talk about that classification then. The sources detail different types. Can you walk us through the main categories mentioned?
Certainly. The sources primarily differentiate based on the microbiology, the types of bacteria involved. Type 1 is the most prevalent form. It accounts for the vast majority, typically cited as 80% to 90% of cases in the literature.
So most cases are type 1.
Yes. And this type is usually polymicrobial. That means it's caused by a combination of different bacterial species all working together.
A mixed infection.
That's right. When tissue cultures are done, you'll typically find a mix, often 4 or 5 different bacteria, including both aerobic species, which need oxygen,
Okay.
and anaerobic species, which can live without oxygen. The sources often highlight what's called synergistic virulence in type 1.
Synergistic virulence, what does that mean?
It suggests that these different organisms somehow cooperate to enhance the tissue destruction and the spread, perhaps beyond what any single one of them might achieve on its own.
They work together to cause more damage.
Essentially, yes. And type 1 is frequently associated with patients who have underlying medical conditions that might compromise their immune system or tissue health.
Okay, so that's type 1, the most common polymicrobial one, often linked to underlying issues. What about type 2?
Type 2 is less common, making up perhaps around 5% of cases, maybe a bit more in some series. This type is monomicrobial.
Meaning just one type of bacteria.
Exactly. Caused by a single, usually highly aggressive bacterial species. And the most frequent culprit here, according to the sources, is group A Hopolytic streptococci. You might know it as Streptococcus pyogenes.
Isn't that the bug that causes strep throat?
It's the very same bacterium, yes. But in necrotizing fasciitis, instead of just staying in the throat, it's invading the deep tissues and causing havoc.
Right, so the same bacteria, but in a much more dangerous place.
Precisely. And interestingly, type 2 can sometimes occur in otherwise healthy individuals, although, of course, having underlying conditions can certainly still increase susceptibility.
Okay, so type 1 mixed bacteria, often in vulnerable people. Type 2 single aggressive bacterium can hit healthy people too. Are there other types mentioned?
The sources do also briefly mention a type 3. This typically involves marine bacteria, like Vibrio vulnificus. It's usually linked to exposure to salt water, often through a wound, maybe a cut sustained while swimming or handling seafood.
The sort of seaside risk.
You could say that. And there's also mention of a type 4, which can be fungal, but this is noted as being exceedingly rare.
Right.
So really, for the focus of our deep dive based on the material, type 1 and type 2 are the most clinically relevant distinctions. They really help inform those crucial initial treatment strategies.
That makes sense. Focus on the main players.
Yeah.
So type 1, the collaborative attack, often when defenses are down. Type 2, the solo assault by a powerful organism, even potentially in someone healthy. Knowing that distinction seems vital for guiding those first steps.
It is, yes. especially regarding initial antibiotic choices.
And what about the specific organisms most frequently cited in the sources for causing NF? You mentioned strep pyogenes for type 2.
Yes, for type 2, group A beta hemolytic strep, S. pyogenes is paramount. It's the classic cause of that rapidly spreading monomicrobial NF.
Okay.
For type 1, in other cases, we see a broader spectrum. Staphylococcus aureus is another common one, and that includes the troublesome MRSA strains, methicillin-resistant Staphylococcus aureus.
Yes, MRSA.
Vibrio species, as we mentioned, are linked specifically to type 3 and that saltwater exposure. And then various Clostridium species and other anaerobes are significant contributors, particularly in those polymicrobial type 1 infections. They're often implicated in the gas production that you sometimes see.
Gas production.
Yes, gas under the skin, which we can discuss more when we talk about signs.
Okay. And how do these bacteria typically gain access? How do they get into the deep tissues in the first place?
The sources are very consistent on this. It usually points to some kind of breach in the skin barrier.
A way in.
Exactly. This commonly follows trauma, but it can be something seemingly quite minor. A simple scrape, a cut, an insect bite, or even a seemingly insignificant puncture wound can serve as the entry point.
It doesn't have to be a major injury then?
Not at all. Of course, more significant trauma, things like crush injuries or open fractures where the bone breaks through the skin, certainly increases the risk substantially.
Makes sense.
But the sources also specifically highlight medical interventions as potential entry points, things like needle injection sites, particularly in intravenous drug users.
Right.
And significantly, it can occur as a complication following surgical procedures. That could be orthopedic surgery, abdominal surgery, really any type involving soft tissues.
It's quite sobering, isn't it, that something as common as a scrape or a routine surgical incision could potentially be the gateway for something this severe.
It absolutely is. It underlines the need for vigilance.
And while trauma might provide the entry point, you mentioned that some individuals are much more likely to develop NF, even from a minor insult. This brings us to the predisposing factors or risk factors. What does the literature highlight here?
Yes, the list of risk factors in the sources is quite clear and, well, quite extensive, actually. As we've discussed, trauma and postoperative status are significant triggers.
The entry points.
Exactly. But a major category involves underlying medical conditions, particularly those causing some form of immune suppression or affecting tissue health and circulation.
Like what specifically?
Diabetes mellitus is repeatedly cited across the sources as one of the most prominent and significant risk factors. Really stands out.
Diabetes, right.
Others include conditions like AIDS, various forms of cancer, chronic kidney disease, peripheral vascular disease, which affects blood flow to the limbs, and obesity is also frequently mentioned.
Obesity as well. Interesting.
Yes. Additionally, conditions that lead to a compromised local tissue environment, things like chronic leg ulcers or venous insufficiency, can also increase vulnerability. Essentially, anything that weakens the body's defenses or compromises tissue integrity.
Diabetes seems to come up again and again in the context of severe infections. Could you perhaps expand a bit on why diabetes is such a significant risk factor specifically for NF, according to the sources? What's the mechanism there?
Yes, this is a critical insight from the literature, and it's multifaceted. Diabetes increases susceptibility to NF through several interconnected pathways. Firstly, chronic high blood glucose levels actually impair the function of neutrophils and macrophages. These are key immune cells, the body's sort of frontline soldiers responsible for identifying and destroying bacteria. So the body's initial response is weakened right from the start.
So the immune system isn't working properly?
Not as effectively, no. Secondly, diabetes often leads to microvascular and macrovascular disease. This means damage to both the small and large blood vessels.
Affecting blood flow.
Precisely. Reduced blood flow means fewer immune cells can get to the site of infection, and it also means less antibiotic medication can reach the area effectively. This hinders the fight against the bacteria.
Makes sense.
And thirdly, neuropathy nerve damage is also common in diabetes. This can reduce sensation, particularly in the feet and lower legs.
So they might not feel an injury.
Exactly. A patient might not feel the early pain signals or even notice a minor wound, allowing the infection to gain a foothold and progress undetected for longer than it might otherwise.
Right, a dangerous combination.
It really is. The sources underscore that this combination, impaired immunity, poor circulation, and reduced sensation, creates a sort of permissive environment where NF can initiate and spread much more aggressively than it would in a non-diabetic individual. It significantly worsens both the likelihood of developing NF and the potential severity and outcome. This is a really key insight for any professional caring for diabetic patients who present with soft tissue concerns.
That explanation makes the connection crystal clear. It's not just one single factor, but really a confluence of vulnerabilities that diabetes creates. It's quite alarming.
It is, and it highlights the importance of managing diabetes well, of course, but also having that high index of suspicion.
The sources also note something interesting, that sometimes NF presents with overlying cellulitis, that superficial skin infection, and sometimes it doesn't. How does that factor into the diagnostic challenge?
Ah, yes, this is another aspect that definitely contributes to misdiagnosis, which the sources highlight as being unfortunately common, especially initially.
Why is that?
Well, cellulitis is a relatively common infection of the skin and the tissue just beneath it. NF starts deeper, down in the fascia. Now, when NF is present, you might see redness, warmth, and swelling on the skin surface that looks very much like typical cellulitis.
So it mimics it.
It can, yes. And this can easily lead clinicians down the wrong path, thinking it's just cellulitis, thereby delaying the crucial suspicion of NF.
Okay.
But, importantly, the sources also note that in some NF cases, particularly very early on, or perhaps when the infection is tracking rapidly along those deeper fascial planes we discussed, the overlying skin may actually appear relatively normal, or have only very subtle changes.
Really? Even with all that going on underneath?
Yes. While this devastating process is unfolding beneath, this means you absolutely cannot rule out NF just because the skin doesn't look dramatically infected. You have to think about what might be happening deeper down. You have to look beyond the surface signs.
Look beyond the surface. Okay, we've covered what necrotizing fasciitis is, how it spreads along those, fascial highways, the types of bacteria often involved, and the significant risk factors, particularly for individuals with conditions like diabetes or a history of trauma or surgery. That paints a very clear picture of a serious, fast-moving threat.
It does.
Let's now transition to perhaps the most critical aspect.
Yeah.
How do you actually recognize this threat, especially when it can be so hidden? And what does the literature say about the urgent management required to fight it?
Right. This is where timely action becomes absolutely vital.
Welcome back. We've established that necrotizing fasciitis is a rapidly spreading, potentially hidden infection. Now, for the crucial part, recognizing the signs before it's truly too late. Given that early presentation can be deceptive, what are the key clinical signs highlighted in the sources? Let's contrast those maybe subtle early clues with the more obvious late findings.
Yes, this is truly where clinical acumen is absolutely paramount, as the sources consistently stress. Early on, as we've touched upon, it can mimic less severe conditions. You might just see some localized redness, warmth, and swelling, perhaps resembling a boil or standard cellulitis.
Okay, fairly nonspecific.
It can be. However, the most crucial early sign, and this is repeated again and again in the literature, is pain that is out of proportion to the apparent physical findings.
Pain out of proportion?
Yes. The patient will complain of excruciating, often deep-seated pain that seems wildly excessive compared to the relatively limited amount of redness or swelling that you might be able to see on the skin.
So it just doesn't match up.
Exactly. That mismatch, that disproportionate pain, should immediately raise a very high index of suspicion for a deeper, more aggressive infection like NF. Other early signs could be subtle things like induration, a sort of hardening or firmness of the tissue when you feel it, and perhaps warmth that extends beyond the visible area of redness, the erythema.
Okay, so pain out of proportion, that's such a vital phrase for everyone to remember. What happens then to the clinical picture as the infection progresses rapidly into those later stages?
Well, as NF advances, the clinical picture becomes much more dramatic and alarming. But, and this is the tragic part, by this point, significant tissue damage has almost certainly already occurred.
Right, the clock has been ticking.
Aleasely, that intense pain we mentioned might paradoxically diminish, or the skin might even become numb anesthetic in the affected area.
Numb. Why would that happen?
It happens because the infection and the resulting tissue necrosis, the tissue death, have actually destroyed the superficial nerves in the skin. So the pain signals stop.
Gosh, so the pain going away isn't necessarily a good sign.
Not in this context, no.
Yeah.
It can be a very ominous sign. At the same time, systemic signs become much more pronounced. The patient will likely develop a high fever, experience chills, rigors, severe shaking.
Generally very unwell.
Very unwell, yes. They often develop clear signs of sepsis, which can rapidly progress to septic shock. In that state, you typically see things like altered mental status confusion, lethargy tachycardia, which is a very fast heart rate, and dangerously low blood pressure requiring medical support to maintain it.
Okay, so systemically crashing. What about the skin itself? What changes there?
The skin changes also evolve dramatically in the later stages. What might have started as mild redness becomes discolored. It might look dusky or violaceous, sort of purplish,
Right.
indicating ischemia, a lack of blood flow due to the damage to the small blood vessels.
Mm.
Bullies, which are essentially large blisters filled with fluid, often clear, serious, or sometimes bloody hemorrhagic, typically develop over the affected areas.
Blisters. Okay.
And eventually you can see overt cutaneous gangrene, that's visible black, dead, necrotic skin appearing on the surface. The induration, that hardening, becomes more extensive, and sometimes on palpation, feeling the area, you might detect crepitus.
Crepitus. That's the crackling sensation. Is that where the gas under the skin comes in that you mentioned earlier could happen?
Yes, exactly that. Crepitus, or subcutaneous emphysema, as it's technically called, is generally a late and rather ominous sign. It's caused by gas produced by certain types of bacteria, notably Clostridium species, which, as we discussed, are often part of those type 1 polymicrobial infections.
So feeling or seeing gas.
Feeling or seeing evidence of gas under the skin usually signifies quite advanced infection, often involving these particularly aggressive gas-forming organisms. So yes, the progression moves from that initial disproportionate pain to severe systemic illness. And these dramatic skin changes, discoloration, blisters, potentially gangrene, maybe numbness, and possibly gas.
That paints a really grim picture of rapid deterioration. Given that the early signs can be subtle and the late signs mean significant damage is already done, how is necrotizing fasciitis actually diagnosed definitively? And what are the challenges involved?
Right. The sources are really emphatic on this point. The diagnosis of necrotizing fasciitis is primarily a clinical diagnosis.
Clinical, meaning based on what the doctor sees and hears.
Yes, based fundamentally on a high index of suspicion, derived from the patient's histories that they tell you, and the physical examination findings. That cardinal sign we keep coming back to, pain out of proportion, is your major alarm bell.
Okay.
While things like imaging and laboratory tests can provide supportive evidence, and they can be useful, the sources stress they should never delay the crucial next step, which is usually surgical exploration.
Don't wait for tests if it looks like NF.
Absolutely not. Now, imaging can sometimes be helpful, particularly perhaps in differentiating NF from simple cellulitis, in cases where the clinical picture is a bit equivocal. MRI is noted in the sources as being able to demonstrate increased T2 signal along those fascial planes.
What does that signal mean?
It basically highlights the inflammation and fluid accumulation down there in the fascia, which is characteristic of NF rather than a purely superficial cellulitis. However, the practical issue is that MRI is often not immediately available 24/7 in many emergency settings. It takes time.
Right, time you might not have. What about X-rays?
Plain radiographs, X-rays are mentioned, but primarily as a way to visualize subcutaneous gas if it happens to be present. But as we said, gas is usually a late finding, and the sources explicitly state that X-rays are not required for diagnosis or for making the decision to treat. You don't need an X-ray to proceed.
Okay. So imaging is supportive at best, potentially time-consuming. What about biopsies? Taking a tissue sample?
Yes, a tissue biopsy can provide definitive histological confirmation. An emergent frozen section biopsy, where a small tissue sample, maybe 1 centimeter by 1 centimeter by 1 centimeter, is taken from the affected area, often at the bedside or in the operating theater, can be rapidly frozen, sliced, stained, and examined under the microscope by a pathologist.
What would they look for?
Histological features consistent with NF include necrosis, death of the fascial layer itself, sometimes the presence of microorganisms within the tissue, infiltration by lots of inflammatory cells, specifically polymorphonuclear leukocytes or neutrophils, and evidence of blood vessel damage like fibrin clots, thrombi within the small vessels.
So it gives proof.
It can, yes. However, and this is another absolutely critical point hammered home in the sources, surgical exploration and debridement should not be delayed simply to obtain a biopsy result. If you have strong clinical suspicion based on the patient's presentation, you proceed directly to surgery. The biopsy might be taken during surgery, but you don't wait for the result before operating.
Don't wait for the test result if the patient's presentation is shouting NF. That really reinforces the urgency we've been discussing throughout.
Precisely. Every minute counts. Now, to try and help quantify suspicion, the sources do mention something called the LRINEC score.
LRINEC.
Yes, LRINEC. It stands for Laboratory Risk Indicator for Necrotizing Fasciitis. It's a scoring system based on 6 standard laboratory values that are usually obtained on admission.
What are those values?
They are C-reactive protein, or CRP, which is a marker of inflammation, the total white blood cell count, WBC, the hemoglobin level, the serum sodium level, serum creatinine, which reflects kidney function, and the blood glucose level.
Okay, 6 common blood tests. How does the score actually function, and what's its intended role?
Well, the score assigns points based on how abnormal the values are for each of those 6 parameters. You add up the points to get a total score. The original study that introduced the Ellernax score suggested that a score of 6 or higher had a high positive predictive value, meaning if the score was high, NF was very likely present.
So, a helpful tool then.
Potentially, yes, but with crucial caveats. The sources also include important nuance from subsequent research. While that original study was promising, larger follow-up analyses have actually shown the Ellernax score to have only modest sensitivity, perhaps around 68%.
Meaning it misses quite a few cases.
It can, yes, but it has fair specificity, maybe around 85% for scores of 6 or greater. So what that means practically is it's relatively good at ruling NF and NEP when the score is high specificity, but is not very good at reliably ruling NF out when the score is low sensitivity.
Right, so a high score is worrying, but a low score doesn't mean you're in the clear.
Exactly. You can definitely have a low Ellernax score and still have necrotizing fasciitis. Therefore, the consensus from the sources is to use Ellernax perhaps as a tool to support clinical suspicion. Maybe it flags up a case you're a borderline about if the score comes back unexpectedly high, but it should never override strong clinical judgment based on the patient's appearance and symptoms, especially that disproportionate pain. Relying solely on a low Ellernax score to delay action could be dangerously misleading.
That's a really important distinction. It's a tool to aid, not replace, expert judgment.
Okay.
And just briefly, speaking of differentiation, the sources mention gas gangrene as a differential diagnosis.
Yes, gas gangrene is another severe, rapidly progressive soft tissue infection. It's often caused specifically by Clostridium perfringens. Like NF, it can cause extensive tissue necrosis and, as the name suggests, it often produces gas within the tissues, leading to that crepitus we talked about.
So it sounds quite similar in presentation.
It can be. Distinguishing clinically between NF and gas gangrene, especially in the early stages, can sometimes be challenging, as both involve severe soft tissue destruction and very rapid progression. The key thing is, both represent surgical emergencies requiring immediate aggressive debridement. The initial management approach is very similar.
Which brings us perfectly to the management principles. If NF is suspected or confirmed, what is the absolute cornerstone of treatment according to all the sources?
The sources are absolutely clear, consistent, and unwavering on this point. The primary life-saving treatment for necrotizing fasciitis is emergent radical surgical debridement.
Emergent and radical.
Yes. Combined with broad-spectrum intravenous antibiotic therapy. The emphasis is on emergent, meaning it needs to happen as soon as NF is suspected, without delay, and radical, meaning the surgeon needs to remove all necrotic, infected, non-viable tissue until they reach healthy bleeding tissue margins.
So it's not just a case of making an incision or draining some pus, it's actively cutting away all the dead and infected tissue.
Exactly that. It's an excisional procedure. And the sources provide a really critical piece of data here. The time elapsed between the diagnosis, or even just the suspicion, and adequate surgical debridement is highlighted repeatedly as the single most important variable influencing patient mortality.
The time to surgery is the key factor for survival.
It truly is. Every hour counts. During the surgery, the surgeon is looking for specific signs of non-viable tissue. Things like a lack of bleeding when cut, a loss of the normal reddish-pink healthy muscle color. It might look gray or pale. The presence of liquefied subcutaneous fat, which is sometimes described rather grimly as looking like grayish dishwater.
Dishwater pus.
Yes, that's a term used. Foul-smelling pus, signs of thrombosis or clotting in the small veins, overt muscle necrosis. The goal is to remove everything that is dead or dying to halt the spread of the infection.
And is one operation usually enough?
Often not, no. The sources frequently state that this often requires multiple trips back to the operating theater over subsequent days, sometimes called second-look operations, to reinspect the area and ensure all non-viable tissue has been removed, as the infection can sometimes continue to spread even after the initial surgery.
Wow, so repeated surgeries might be needed. That surgical urgency is clearly paramount. What about the antibiotic component? You mentioned that too.
Yes. Aggressive, broad-spectrum intravenous antibiotics must be started immediately upon suspicion or diagnosis. Ideally, even before the patient actually goes to the operating theater.
Why broad spectrum initially?
Because, as we discussed, type 1 polymicrobial infections are common, and type 2 caused by S. pyogenes is highly aggressive. The initial empirical therapy, the treatment you start before you know the exact bugs, must cover a very wide range of potential pathogens. That includes gram-positive bacteria, gram-negative bacteria, and anaerobic bacteria.
Covering all the bases.
Essentially, yes. A typical initial regimen recommended in the sources might include a combination, for example, of penicillin or the similar broad-spectrum beta-lactam agent, plus clindamycin, plus an agent that covers gram-negative bacteria well, like an aminoglycoside or perhaps a broad-spectrum cephalosporin, and often metronidazole for specific anaerobic coverage.
That seems like a powerful cocktail.
It needs to be.
Oh.
Interestingly, clindamycin is particularly noted in some sources as potentially reducing mortality and also the odds of needing a limb amputation.
Why clindamycin specifically?
The thinking is likely because it works by inhibiting bacterial protein synthesis. This means it can reduce the production of harmful toxins by organisms like S. pyogenes, over and above just killing the bacteria.
Ah, so it tackles the toxins too.
Potentially, yes. Now, once tissue and fluid cultures, which should always be taken during surgery and sent for urgent microscopy, culture, and sensitivity testing, MCS, come back from the lab.
Which tells you exactly what bacteria are growing.
Exactly, and what antibiotics they're sensitive to. Once those results are available, the antibiotic regimen can and should be tailored. It might be de-escalated to more targeted agents or adjusted based on the specific organisms identified.
Makes sense. So you start broad, then narrow down if possible.
Precisely. For instance, if it's confirmed to be S. pyogenes or Clostridium, high-dose penicillin G is often the definitive agent of choice. For polymicrobial infections, broader agents like imipenem, durapenem, or meropenem, which belong to the carbapenem class, might be continued or used. And if MRSA is suspected or identified, then agents like vancomycin or daptomycin need to be added or used.
Okay, so it's a really powerful combination. Immediate surgical removal of all the damaged tissue and a heavy-hitting, initially broad, then targeted antibiotic regimen to kill the remaining bacteria. Are there any other adjunctive treatments mentioned in the sources? Things used alongside surgery and antibiotics?
Yes, the sources sometimes mention hyperbaric oxygen therapy, or HBOT, as a potential adjunct.
Hyperbaric oxygen, what does that involve?
This is particularly considered if an anaerobic infection, such as one involving Clostridium, is confirmed or strongly suspected. Hyperbaric oxygen involves placing the patient inside a sealed chamber and exposing them to 100% oxygen at an increased atmospheric pressure, usually 2 to 3 times normal air pressure.
And how does that help?
Well, the theory is that the very high oxygen levels achieved in the tissues can be directly toxic to anaerobic bacteria, which, as we know, thrive in low oxygen environments. It might also theoretically improve oxygen delivery to tissues whose blood supply is compromised, potentially enhancing the function of the patient's own immune cells, like neutrophils, and possibly aiding wound healing.
Sounds potentially useful. Is it commonly used?
The evidence for its routine use in NF is actually mixed, and it's certainly not universally available. Crucially, the sources emphasize that HBOT should never delay the primary treatments, that is, surgical debridement and appropriate antibiotics. Those remain the absolute priorities. HBOT is, at best, an adjunct to be considered in specific circumstances if available and if it doesn't interfere with the core therapy.
Right, mainstays first.
Sadly, despite all these aggressive measures, surgery, antibiotics, maybe HBOT, the infection, can sometimes be so extensive or the patient so critically unwell that more drastic measures are needed. Is that correct?
Yes, unfortunately, amputation is a grim reality in some severe cases of necrotizing fasciitis, particularly when it affects a limb extensively.
Amputation.
The sources note that clinicians should maintain a low threshold for considering amputation if the limb is clearly non-viable, meaning it cannot be saved, or if the extent of the infection within that limb poses an ongoing, overwhelming threat to the patient's life, even despite attempts at debridement. Sometimes, sacrificing the limb is tragically necessary to save the patient's life.
A devastating decision, but sometimes unavoidable.
Sadly, yes.
And even for those fortunate enough to survive the initial infection, the journey doesn't necessarily end there, does it? The extensive tissue removal must leave significant wounds behind. Absolutely, that's a very important point. Once the infection is controlled through those serial debridements and the antibiotics, the patient is often left with very large, complex, soft tissue defects, basically. Big holes where tissue used to be.
Right.
Achieving definitive wound closure then becomes the next significant challenge, often requiring input from plastic and reconstructive surgeons. This phase can involve procedures like skin grafting, where healthy skin is harvested from another part of the patient's body, like the thigh, and transferred to cover the defect.
Skin grafts.
Or, for larger or more complex wounds, it might require even more complex surgical flaps. These involve moving sections of tissue, which could be skin, fat, fascia, or even muscle, along with their own intact blood supply, from a nearby or sometimes even a distant area of the body to cover the critical defect.
That sounds like major reconstructive surgery.
It often is. The recovery and reconstructive phase can be very prolonged and demanding for the patient, both physically and psychologically. And even with successful reconstruction, patients may still be left with significant functional impairment, chronic pain, or cosmetic deficits, depending on the site and extent of the original infection.
It really sounds like a devastating infection with consequences that reach far beyond just surviving the initial acute phase. What do the sources ultimately say about the overall prognosis? What are the survival rates like? And what are the key factors that predict outcomes?
The prognosis for necrotizing fasciitis, despite all the advances in critical care, potent antibiotics, and refined surgical techniques, remains quite sobering. The sources consistently report significant mortality rates.
How high are we talking?
Well, one source we reviewed cites mortality as being as high as 25%, so 1 in 4 patients. Another source suggests figures around 32%. These are high numbers, and they really underscore the inherent severity of this condition and why it truly is a race against time.
A quarter to a third mortality rate? That's
Yeah.
incredibly serious.
It is. And the sources also identify some key predictors of mortality, which really reinforce the points we've already touched upon.
Such as?
The most consistently cited and arguably the most powerful predictor is, again, the time from presentation or diagnosis to adequate surgical debridement. Delays in getting the patient to the operating theater for that crucial first surgery are strongly correlated with increased mortality.
Time is tissue. Time is life.
That phrase is very apt here, yes. Other factors identified as predictors of worse outcomes include advanced age, the presence of significant comorbidities, underlying health problems like diabetes, immunosuppression, peripheral vascular disease, and the development of severe systemic complications, such as septic shock that requires vasopressors.
Vasopressors. Those are drugs to support blood pressure.
Exactly. The requirement for vasopressors outside of the controlled environment of the operating theater is a strong indicator of a severe systemic inflammatory response and developing organ dysfunction, and it carries a poor prognosis.
Those figures and predictors truly drive home the importance of everything we've discussed, that need for early recognition, prompt suspicion, and immediate aggressive intervention. Thank you for walking us through all of that in such comprehensive detail. It's been incredibly insightful.
You're welcome. It's crucial information to understand.
Absolutely. Let's try and wrap up now with a quick lightning round just to solidify some of the absolute key takeaways for our listener. Professor, thinking about professionals perhaps outside of the immediate medical team or even a patient themselves, what's one critical sign they might encounter or experience that should really trigger alarm bells for potential NF?
Pain. Pain that is significantly out of proportion to whatever visible physical signs might be present.
Okay. And the single most important immediate step in managing suspected or confirmed NF?
Emergent surgical debridement.
Mm-hmm.
Getting to theater fast. Time is absolutely critical.
Got it. And a key microbiological difference between type 1 and type 2 necrotizing fasciitis.
Type 1 is typically polymicrobial, caused by multiple bacterial species working together. Type 2 is usually monomicrobial, caused by a single species, often strep pyogenes.
Polymicrobial versus monomicrobial. Okay. One significant underlying medical condition that dramatically increases a person's risk for developing NF.
Diabetes is probably the most commonly cited and significant one, but really any condition causing immune suppression or poor circulation increases risk.
Right, diabetes or immune issues. And finally, beyond surgery and antibiotics, what's another potential treatment that's sometimes mentioned, albeit one that definitely shouldn't delay those mainstays?
Hyperbaric oxygen therapy, or HBOT, particularly if anaerobic bacteria like Clostridium are involved.
Excellent. Those rapid-fire points are really great anchors for memory. Thank you. All right, let's take a moment then just to summarize the really actionable insights from this deep dive into the source material on necrotizing fasciitis. What should you take away? First, necrotizing fasciitis is rare, yes, but it's an extremely aggressive soft tissue infection. It spreads rapidly along those fascial planes beneath the skin, and it can often originate from even minor trauma or surgery.
that rapid spread is key.
Second, a critical early warning sign, possibly the most important one, is severe pain that appears completely disproportionate to the physical appearance of the affected area. You really have to look beyond the surface signs.
Trust the pain report.
Third, individuals with underlying conditions like diabetes, any form of immune suppression or obesity, as well as those who've recently experienced trauma or had surgery, are at significantly increased risk. Vulnerability matters.
Risk factors are important context.
Fourth, prompt clinical suspicion is vital, and this must be followed by immediate aggressive surgical debridement to remove all the dead tissue, combined with early broad-spectrum intravenous antibiotics. These are absolutely essential for survival and for improving outcomes.
Surgery and antibiotics urgently.
And finally, number 5, mortality rates remain disturbingly high, which really emphasizes the life-threatening nature of this condition and underlines again that critical importance of speed in both diagnosis and management.
It remains a very serious challenge.
It certainly does. That brings us to the close of this deep dive into necrotizing fasciitis. Professor, thank you so much again for guiding us through this complex and frankly quite frightening subject with such clarity, drawing directly from the sources provided.
It was my pleasure. As I said, it's vital information for professionals across many fields to be aware of.
Indeed it is. And if you, listening, found this deep dive valuable, please do consider rating the show or sharing it within your professional network. It genuinely helps others find these important insights. Finally, let's leave you with a thought for reflection, based on everything we've discussed today. Given the lightning speed at which necrotizing fasciitis can develop and the documented difficulty in spotting its subtle beginnings, what does this condition ultimately teach us about the critical importance of really astute observation in clinical practice, perhaps trusting our clinical intuition even when initial tests might seem inconclusive, and maybe even empowering patients to voice their concerns emphatically when something feels profoundly wrong to them?
An important question to ponder.
Something to think about. That's all for this deep dive. We'll join you next time.